Witam wszystkich pięknie. Ja się nazywam Łukasz Wysoczański, jestem cukrzykiem typu pierwszego i za chwilę obejrzycie mój wywiad z doktorem Bernsteinem. Kim jest dr Bernstein? Znajdziecie na stronie sposób na cukrzycę.pl. To tak pokrótce tylko powiem, że jest autorem tej książki o kierowaniu cukrzycą i insulinopornością. Ja jakiś czas temu podjąłem się trudu przetłumaczenia książki doktora Bernsteina i wydania jej w języku polskim. Tutaj jest okładka już trzeciego wydania tej książki. Jestem też autorem własnej pozycji książkowej o tym, jak zarządzać cukrzycą typu pierwszego i cukrzycą ogólnie insulinozależną. Założyłem w tym roku fundację o nazwie Normoglikemia, żeby szerzyć informacje na temat zdrowia metabolicznego, na temat tego, jak można w umiejętny i bezpieczny sposób kierować swoją cukrzycą w taki sposób, żeby nie dopuszczać do powikłań cukrzycowych tak zwanych. Także ta fundacja zajmuje się szeroko pojętą edukacją. W tym roku kalendarzowym udało mi się z funduszy fundacyjnych zrobić 2 konferencje popularno-naukowe i liczę na to, że w przyszłym roku uda nam się kolejną zorganizować. Dlatego jeżeli macie taką możliwość, to zachęcam do darowizn, do wpłat. Numer konta będzie podany podczas trwania seansu, czyli wywiadu z doktorem Bernsteinem. A tymczasem zapraszam wszystkich serdecznie do obejrzenia wywiadu. Trzymajcie się, na razie, hej.
Hello, Luke.
Hello, Dr. Bernstein. Thank you very much for accepting this invitation for an interview. I perceive you as an inspiration, as a mentor, as definitely an authority in diabetes. Therefore, it is my great pleasure to perform, to do this interview with you. I don't know how much time we've got, but
I've left as much time as you need.
Right, brilliant. That's fantastic. So what I'll do, I'll start off with a question about your motivation to actually go into medicine, because I've read the book, obviously, because I've translated it as well into Polish, and I'm in a sort of similar situation maybe to you. That's why that's probably a personal question that I wanted to ask, because I know one of the motivations for you to actually go into medicine was because back in the day, there was an internet around. So your only way to actually get published, so get your work, your book published, was to become a doctor yourself. Otherwise, you wouldn't be treated with respect and with honor, and no one will take you seriously. But thinking from a different perspective, you were, if I'm not mistaken, 45 at the time. So you had a family, you had a wife, you had kids. How did they, react to your idea of actually pursuing a completely different career? Because if I'm not mistaken, you were a director at a company at that time as well. So it's a life-changing moment for you as well, wasn't it?
Well, my wife, I had put my wife through medical school 20 years prior to my graduation.
Right.
And she had been after me to go to medical school when I had no interest in it and did not want to. And I had seen what she had to go through, the hours, the mistreatment, et cetera, et cetera. And no way did I want that. However, when I about 2 years after I got my own blood sugar straightened out, this was about 1973, I was actually sitting in the bathroom at midnight. I got the urge to go in the middle of the night, And I had this image that I had been in a kind of concentration camp most of my life and had escaped. And there were still millions of people still there, and I could get them out. I had the answer. Another expression that came to my mind was a better mousetrap. I had an invention that would enable them to control their blood sugars. It was measuring blood sugar, measuring my own blood sugars, measuring theirs. And I didn't know what to do about it, but I decided to write a paper. I was already on the board of trustees of the New York Diabetes Association. They were all doctors except for two of us, the treasurer and me. I was on the board because the president at that time I had actually taught him blood sugar monitoring and the tricks I used for treating myself, which were basal bolus insulin, which didn't exist then. I invented it.
Yeah.
And a low carbohydrate diet. And he was using it for his patients with great success. So he asked me to be on the board of trustees of the New York chapter. And I got to know all of these doctors. I was friendly with them, and I was a pretty young fellow at the time. They were all much older than me. So they looked at me as a smart guy, and I figured I could convince them to do what I was doing for their patients.
No chance. Yeah.
No way. My own doctor was president of the American Diabetes Association, and he said, patients come here once a month to get a blood sugar. If they could measure it themselves, they wouldn't come here. They'd save money, and I'd get none. I'd be bankrupt.
Well, guess how it turned out. It's not that simple after all, right?
And it turns out that I got to speak to subsequent presidents of the American Diabetes Association, because usually in those days they came from New York, and they were people I knew.
Yeah.
And they all gave me the same answer. Another statement. It's hard enough to get a patient to inject himself once a day. You want them to inject themselves 3, 4, 5 times a day. Forget it.
Yeah.
And the fact that they were injecting a huge amount of insulin, maybe 100 units at a time, and I was giving tiny mini doses.
Yeah.
And I had a method that didn't hurt. They weren't interested in learning how to make an injection that didn't hurt.
Yeah, that was actually my other question, because you've invented, like you said, you've invented the basal bolus, so multiple daily injection system. You've invented the blood sugar monitoring by the patient themselves, because obviously with the invention of the first glucometer it became possible, but still they wouldn't allow for the patients.
That was used for emergency rooms.
Exactly.
To tell the drunks from the diabetics.
Yeah, that's
Here it is. It weighs, I think, 3.5 pounds. And I built I took 2 little 9-volt batteries.
Right, so you could carry it through.
To get this thing operated on 9. This operated on, I think it was 9 volts DC. But to get the 9 volts on a rechargeable battery, you had to have 2 9-volt batteries.
Yeah.
And you put them in series with, should have been 12 volts, but it would turn out in those days to be 9 volts. And I made this whole little contraction to plug into the meter, make it portable. And I would carry this 3.5-pound thing in a shoulder bag with me wherever I went.
Yeah, exactly.
And if I was going to someone's office, I would have it with me, and before I might be waiting in an anteroom. This is in business, and I would look for a plant, because we had a squeeze bottle to squirt water on the blood sugar strip to wash off the blood, and then you had to blot it on a Kleenex. And where would I squirt the water? So I would look in the offices for a plant, and I'd go to the plant and squirt the water on my strips.
Yeah, absolutely. So the question I've got there is, did you get any sort of, I would say, exoneration or vindication for, because obviously you did have some bad press, and obviously you still do, in terms of, if you ask the run-of-the-mill endocrinologist about reducing the amount of carbohydrates in the diet, it's also one of your sort of advocacies or inventions. You still get at least a bad look as a patient.
We get more than that. We get endocrinologists threatening patients, especially threatening the parents of children. I'll have your child taken away. We'll give your child to foster parents. Usually they'll threaten if the A1C goes below 7, which is an average blood sugar of around 180, which is almost 2.5 times normal. And there's a major insurance company that also has physicians on their staff that treat patients. So they own hospitals, they have many physicians, and this company will not give, the physicians will not allow my patients to get insulin. They won't approve insulin from their insurance because they say they're non-diabetic because they have blood sugar A1Cs of 4.8 or 5. They tell them they're not diabetic, but they're taking 5 shots of insulin a day.
Obviously, yeah. No, that's
so
criminal.
We have many crazy things. As far as the great bulk of the medical profession is concerned, diabetics are not entitled to the same blood sugars as non-diabetics.
Yeah.
And it's, in this day and age, it's still going on.
Yeah, that was one of the reasons actually that I've taken upon of translating your book into Polish, because I've sort of realized exactly the same thing was and is happening back in Poland.
Now, are you in Poland right now?
At the moment, no. I'm in England. So like I said, I see you as an authority in diabetes, and what came out of my sort of quest in disseminating your principles of managing diabetes is that I sort of realized myself that I would like to become a doctor as well. So I'm doing like a preparation to medicine course in the UK, in England.
Okay, well, good luck. It's a tough grind.
It is. That's the reason why I've asked the first question, because I'm not a spring chicken myself. I've just turned 40 myself, and it's difficult. Maybe also a question to you, because you went through the same thing. So you were, like you said, you were one of the oldest, or the oldest in the classroom, not only back in college but also at university. And then
no, in college I was the youngest in the classroom.
You were the youngest, yeah. But back at university, you were probably the oldest. Knowing
at the medical school, I was the oldest. Yeah.
And knowing what you already knew at that time about the detrimental effects of hyperglycemia, and also when working at various hospitals at the beginning of your career, you must have seen a lot of patients who didn't know how to manage their diabetes properly. So the question was, did you then try already to let's say put the word out and say to people that this is not the way to treat diabetes, or you weren't allowed actually to speak your word?
Well, basically, when I was in medical school and rotated through the Department of Medicine, there were a lot of type 2 diabetics on the floor, people with heart disease and whatnot.
Yeah.
There were also people who had what was called syncope, or what is called syncope or near syncope, who were being misdiagnosed. So aside from their diabetes, I was the only one of all these people, a whole floor full of doctors and residents and so on, who realized that many of these people had postural hypotension, either due to diabetic neuropathy or due to low blood pressure. And I was the only one I would measure their blood pressure, supine. They would come in and get a battery of, they'd be in the hospital for 4 days, getting all kinds of tests for their heart or their brain. They either claimed they had a stroke. The doctors would claim they must have had a stroke or a heart attack, and they're trying to document this. And all I'm doing is measuring their blood pressure, supine and standing, and we see a dramatic drop when they stand, and they feel like they're going to pass out if they suddenly stand. And I got ridiculed. It was so obvious what was going on, and yet doctors were seeing it with their eyes and ridiculing it. And I would rapidly get my patients who were diabetic. They didn't have a battery of oral agents in those days. They didn't even have metformin. They had one drug, a sulfonylurea, and it was not widely used then because it was believed that it caused heart disease.
Right.
And there is still evidence that it can cause heart disease, sulfonylureas. But so I had insulin with me, and we were allowed to prescribe, and the pharmacy in the hospital would honor our prescriptions if the resident or the attending didn't interfere. And I would give them small doses of insulin and instruct them about diet, and I'd get into battle with the dietitians. And I was actually in 3 different hospitals. And in 2 of the 3, the dietitians, who were all fat, because they were on high carbohydrate diets trying to lose weight, that they thought that diet would help them lose weight. That was the gospel. It's still the gospel today.
It is, yeah.
And the chief dietitian would usually be a fat lady, and she would ask me if I would get together with all her dietitians, and tell them about low carbohydrate diet because I claimed that they could lose weight on
Okay.
it.
Well, I can
but
only tell
the
you that things haven't
attendings,
changed much.
now, some of the attendings, the ones that were permanently affixed to the hospital as employees, professors and whatnot, they would battle with me and didn't want my patients to have normal blood sugars. But the volunteer attendings from the outside would frequently be sympathetic and fascinated and ask for more information. There were usually people who had separate specialties other than medicine.
Yeah, that sounds about right. That's still the case, fortunately or unfortunately these days. So my story, because I'm a type 1 diabetic myself, was exactly the same. I was, the very first time I was summoned to a dietitian's office was because I, unfortunately to myself, told my endocrinologist that I do follow your protocol, which basically means very low carbohydrate diet. So obviously I was summoned to the dietitian's office and I was greeted by a lady who was, I think she was already obese. She wasn't even overweight. She was obese, and she started lecturing me about the importance of carbohydrates in diabetics diet. But let's just leave that aside because
Yeah, well, when I use the word fat, I really meant obese.
Yeah, okay, all right. Speaking about profession of doctors, some time ago, I came across Dr. Angers, or was he a professor? I don't remember now. So, and anyway, a doctor in endocrinology, actually saying during the Banting Memorial Lecture that the problem with diabetes is not essentially the related with insufficient insulin being secreted, but too much glucagon actually being secreted by diabetics' body. There was obviously some other research around this as well. Now, we've heard recently that there has been some successful cure for type 1 diabetes by some sort of it wasn't an artificial pancreas. I think it was more related to either I don't remember now, but there was one transplantation of beta cells, I think, done in China, and another one done in the US. So the question to you is any of those methods, as far as you know, really successful? Do you think we've actually turned the corner and there is some sort of hope for diabetics?
I've read a number of papers claiming cures. The classic one was what was called the Edmonton study. It was done in Canada a number of years ago, and they did islet transplants, and on something like 22 people, and they had one young lady who they claimed at 3 years after the transplant only required a tiny amount of insulin. And they boasted that they had essentially cured her. But her hemoglobin A1C was something like 8. They claimed that was a cure.
Okay.
And there was no follow-up on what happened to her another 3 years later. And she was immunosuppressed. They had her on
exactly.
immunosuppression, which, for my money, is worse than diabetes.
Yeah. So it's not really. Do you think that we're actually nearing that discovery, or is that unlikely due to the amount of money that is actually in this business of managing diabetes?
I don't think that. I think that there are still some researchers who are being funded, but the funding is going into all kinds of bizarre things, like psychological statistics on what ethnic groups are being treated in what way, and things like that.
Yeah.
You'll get some money going to basic research, learning about physiology. But it's very rare that money gets directed to finding a cure, because there are not, in this day and age, good ideas for a cure yet. Down the road, maybe there'll be some genetic modifications where if you can change the genes in a living person and cause them, the genes causing them to make new beta cells, we do know what some of the precursor cells are.
Yeah.
I can think of two precursor cells that are well known. One is the cells that line the pancreatic ducts, the ducts that secrete enzymes. Those are basic cells that can be converted to beta cells.
Yeah.
And then their glucagon cells can also be transformed into beta cells.
Yeah, I've read that one as well.
One problem with that, however, even if you could do it, is the ones in the pancreatic ducts don't have the kind of nearby circulation. You need capillaries carrying blood right on top of the beta cells to get the insulin. And the ductal cells are not so located. The glucagon cells might be so located. So yes, one potential solution would be to convert glucagon cells into beta cells. And I don't know of any work going on attempting to do that. I think that we have to know more about genetics.
Right.
They're hoping that artificial intelligence plus quantum computers might be able to come up with some sort of genetic method of accomplishing
that's
things.
quite interesting. Okay. Let's stay in the topic of medicine and but move a bit away from, let's say, the professional world of medicine. I wanted to ask you, because I know for a fact, maybe it was a year, maybe 2 years ago, you said on one of your tele-seminars that you actually wanted to rewrite your book, or write your book from scratch, because it has passed, I don't know, 10, 12, maybe more years since you've last edited your book. And because of the ever-changing nature of medicine, there are some new sort of advancements like insulin pumps and the newest CGMs and whatnot, that there is a need for you to update your book. Has there been any feedback?
It's actually in process. I didn't have time to do it myself.
Right.
But I was contacted by a physician in China who's a type 1 diabetic,
Right.
who knows English, and who read my book and used it on himself and felt that he owes me his life. And he wanted to translate my book into Chinese.
Yeah.
And we arranged negotiations with my publisher and a Chinese publisher, and so very complicated. And he submitted, I told him we have to, if you're going to translate this book, let's update it and have a Chinese version that's updated. And then after it's published in China, would you be willing to translate it back to English with the corrections? And I've been corresponding with him via email and updating the chapters where we have to introduce new things.
Yeah.
It's interesting that way back in 2011, I was using GLP-1 agonists to curb appetite. You see that in the book, right?
Yes, exactly. And now it's
and
a big
I was the first one to do it.
Yeah, exactly.
And again, I was being ridiculed for that. And now it's a billion-dollar industry.
Exactly. Yeah. Yeah, definitely. Actually, about those corrections, there's one I wanted to ask you about, because I get some questions about it from our Polish users, because you state in one of the chapters in your book, apart from the fact that obviously vitamin C reacts with the reagent on the blood glucose strips, which basically means that you can't really tell if the reading is correct or not. But you've stated something about large doses of vitamin C also could lead to neuropathy in diabetics.
Yeah, now that I got out of a study that was reported in the journal Diabetes Care years ago.
Right.
I didn't know about this neuropathy until I read an article.
Right. Okay.
And so I only saw it once. But I can see in general, it doesn't make sense to take large doses of any vitamins.
Interesting. Okay. All right. What about cholesterol then? Because that's another one where the Polish readers are seeing a trend. So I would say maybe 1/4, maybe 1/3 of people who actually stick to the diet see an elevation in their blood cholesterol.
Okay, well, I'll give you my usual answer.
Okay.
Number one, there have been many studies that do not relate total serum cholesterol to heart disease. But there are subfractions that do relate. For example, small dense LDL is believed to be a culprit. And oxidized LDL, by the way, I was a pioneer in something else, getting laboratories to test oxidized LDL.
All right, interesting.
And that was because I read a historic study going back to the 1920s, where a pathologist did autopsies on soldiers who were killed during the First World War and found on the inside of their arteries deposits not of LDL, but of oxidized LDL. And I said to myself, my God, I didn't know that. That's what we should be looking at, the oxidized LDL. And I did some hunting and discovered that there was a small company in Brooklyn, New York, that measured oxidized LDL. And I started sending my patients blood. I had to send frozen blood, I believe,
Wow.
to them by messenger. And eventually they sent me a white box to put outside my house where they would have their own people pick it up.
Yeah.
And I had usually been dealing with a large laboratory called LabCorp in the USA that did all my other tests. And I had gotten friendly with the top people at LabCorp because we had written a joint paper of another discovery I made relative to protein in the 24-hour urine. And so I was friendly with the top guys at LabCorp, and I told them about oxidized LDL, and I said, can I introduce you to these people in Brooklyn?
Yeah.
And I got them to phone the president of the company in Brooklyn, and I said, would you be willing to send your bloods to Brooklyn and put oxidized LDL on your menu? And they did. Now they're doing it themselves at two laboratories in the USA, one on the West Coast, one on the East Coast. So oxidized LDL is now on the LabCorp menu, and it's also on another big laboratory menu, again, because I got them to do it. And so their triglycerides also have a strong correlation with heart disease. So you don't look at total cholesterol, you look at small dense LDL, you look at which is available but expensive.
Yeah.
You look at oxidized LDL, and doctors are not ordering this because they don't read the scientific literature. They don't have time. So they don't even know about these things. Also, lipoprotein small a, I discovered, was unbelievably important. I discovered that many years ago when I had a lady patient who was 50 years old, type 2 diabetic, pretty mild, but she had a heart attack before she came to me and became my patient.
Wow. So she wasn't even 60. She was in her 50s and she had a heart attack.
Yes.
Wow.
And she and her husband were ballroom dancers, and they would dance for 3 hours every night. So she got tremendous. I used to be a dancer when I was much younger, and I know about the effort in ballroom dancing. It is tremendous.
Yeah.
If you do the fast stuff. And so she was getting tremendous exercise every night, and yet she had a heart attack.
Unbelievable.
So I had read somewhere that estrogen deprivation in women could cause elevated LP small a.
Yeah.
Well, and I tested everybody for all these weird correlates.
Markers. Yeah.
And she had an LP small a of 175, where normal was, I think, up to something like 20 or something like that.
Okay.
So hers was sky high. And I asked her, does she have any reason to be estrogen deprived? She had a total hysterectomy when she was 30 years old. No ovaries. So she was deprived of, and no one gave her estrogen replacement. So she couldn't have any children, but she had no estrogen for 20 years. And so I realized that the culprit for her heart attack must have been this high LP small a.
Right.
And I've tested it on other people. And again, when I had two men who had heart attacks before they became my patient. They both had elevated LP small a. So it was not, I didn't have a big population, but I drew a conclusion anyway that appears to be true.
Right.
So, and people are not looking at these.
No, they're not. So what are you afraid of subscribing statin drugs then? Because obviously once you have a high risk patient who's, let's say, whose markers are elevated through the roof sometimes, is that something you tend to do, or how do you come about people with high risk of actually getting some sort of myocardial infarction or any other type?
Well, I believe that aside from, let's say, LP small a, which can be treated in women by giving them estrogen. By the way, her LP small a came way down when we put her on estrogen. I believe that their biggest risk factor for dying is the high blood sugars. So it does not, so the fact that someone has already had a heart attack or has a stent in place or had a stroke or whatever doesn't discourage me from aggressively treating their blood sugars.
Right. Okay. That's okay. That's very interesting. Okay. Speaking about patients, a lot of people ask me, because they've read your book, and they ask me, okay, but once I've started, let's say, following Bernstein's protocol, my hunger ceased. So I can't eat 3 times a day. I eat twice a day, and it's enough. And the question
I hear a lot of that
is, and they're asking, is this normal, and is that okay?
It is okay.
That's what
it is okay. Yes, and we try to not make the dinner, the evening meal, the largest meal, because most people who are already diabetic already have gastroparesis. That's another thing that's ill-recognized by physicians. Most physicians have heard the word in medical school. They're seeing patients with it every day and don't realize it.
Yeah. And I've read the latest so-called NICE guidelines in the UK, which are guidelines for diabetics, and essentially they're even mentioning this complication as a common one. But like you state in your book, I think as well, they usually first, well, what they do is they give the suspect patient this isotope to eat with a meal, and they try
Yes.
to, but it doesn't work that way,
Right.
unfortunately. So
So you
that's
can see when, and I think that I end up being stuck as primary care physician for many patients because their primary care physicians don't seem to know much medicine or don't practice intelligent medicine. So I stumble not only on problems with dealing with diabetes, but problems across the board. I especially see problems when it comes to things like foot care, treatment of wounds, and so on. I discovered several, how shall I put it, tricks for aggressively healing wounds. One of which is a medication that's been used for dogs for 100 years, but was never submitted to the FDA for approval on humans because it's a generic product.
So you can't make a lot of money on it, right?
Right. So no drug company is going to come out with it, but it's being sold. It's a variation of bleach, a modification of the molecule of bleach, and it accelerates wound healing tremendously. I initially started using it on myself and my family. And now for years have recommended that all of my patients, as part of their inventory of medications and supplies, have some of this on hand in case they get injured.
Interesting.
And if you're traveling, especially if you're going overseas and you might not have trouble purchasing pharmaceuticals overseas, have this with you in your luggage in case you get hurt.
Yeah, definitely. That's is that going to be in the revised version of the book?
It'll be in the revised book.
Fantastic. Okay. I wanted to ask about another invention of yours, which is the glucograph form for recording the blood sugar. Do you still use it? Do your patients still use it, or do you rather look at the CGM reports? Because
I should have my copy handy. I think I have it inside, and I'll bring it in. Just give me a minute.
Yeah, that's fine. Yeah.
Sorry to keep you waiting.
That's okay.
I usually have it in this pocket over here. And I use it for myself.
Yep.
Here it is.
There we are.
And we're near the end of a week. So I'm over. There we are.
There we go. Yeah, exactly. So the reason why I'm mentioning it is lately I've been in touch with parents of a young type 1 diabetic, and they've shown me some sort of booklet where they keep logging in their child's blood sugars, and you couldn't make any sense out of it because the way it was done, you couldn't draw any conclusions from the records they kept putting in. And that's exactly the case also with the CGM reports. At least that's
that's right. Yes.
That's my impression, that these tools that the diabetics are given, they're not invented or made by people who are actually diabetics, and they don't even understand that by trying to help in this way, they're not really helping at all, because you can't analyze the data in that way. That's why I find your glucograph method so easy and fantastic, because you can easily see patterns in what happens to your blood sugars.
That's right. That's right. How shall I put it? The whole scenario is a lack of understanding and interest on the behalf of the professionals. It's very rare that I run into a professional who has any interest in the well-being of the patients, or even in the true science of what's going on. Years ago, the medical director of Eli Lilly was, I believe his name was John Galloway, was very interested in the science, and he did interesting experiments. And he even wrote a recommendation, I think, on the cover of my first book.
All right.
I remember he did an experiment that impressed me considerably. He gave an intramuscular injection of regular insulin to a non-diabetic man and had him hooked up to an IV glucose drip. And he would check his blood sugar every half hour. They didn't have these meters in those days. But I think it was every hour, because it took an hour to get a blood sugar. And if the blood sugar was below a certain point, they'd increase the glucose. The glucose was dripping in constantly to offset that insulin.
Yeah.
And if the glucose started dropping, they'd speed up the drip.
Yeah.
If it started rising, they'd slow down the drip, as if he had an artificial pancreas. And I always, when I tell this story to doctors, I ask them, how long do you think it took before they could stop dripping in the glucose so that he wouldn't get hypoglycemia? And the doctors would say, well, you guess. It's in my book. He said, you know the answer.
I know the answer. Yeah.
Okay. So they usually guess anywhere from 3 hours to 6 hours, and it turned out to be 5 days.
Yeah, exactly. So,
and the point that I made was that the length of time that an insulin injection works depends upon how much you inject.
Yeah.
It's a simple mechanical problem.
It is, but they don't perceive it that way.
Yeah.
And actually, these days, when a young person gets diagnosed with diabetes, the first, let's say, the first resort is to offer a pump, an insulin pump, as a way of the doctor, at least that's my impression, resigning any responsibility for the care of the patient, because then they could say the pump will take care of your blood sugars, which isn't the case, obviously.
That's the same in the USA. Very frequent. And if the family turns down the pump if it's a kid, they start threatening.
Yeah. But even if, because okay,
it's a way of taking away responsibility.
It is,
because and they know that they don't know how to treat diabetes.
Yeah.
They won't admit it, but they know it.
Yeah, that's what it is. Plus also, even with the, the Omnipods, I think that's what they're called, where it's tiny, it's minusculous, so they try to put it on kids as young as, I think, 2 or 3 year old. It still doesn't do the trick, because without the proper diet, without the proper knowledge, the parents don't know any better. You end up on a roller coaster anyway. It doesn't do anything. Yeah. I wanted to actually ask you about the insulin pumps as well, because I follow the Type 1 Grid community, the Facebook community, which obviously follow your rules, but a lot of them actually, they do it up until the point of insulin therapy. So there are people who have blood sugars, I would say, okay, HbA1cs in, let's say, low 5s. Some of them are so good that they can even achieve normal blood sugar, so high 4s or just 5% of HbA1c. Has your stance on insulin pumps changed, seeing those numbers, seeing those results, or do you still feel or think that they are still playing with fire, even though their results from the perspective of let's say normal endocrinologist these days would be just saying, just keep on the good work and you're doing tremendously well, and what would you say to that?
I'd have to look at the individual situations.
Mm-hmm.
There is still an average of 1 infection per year, or abscess at the infusion site. There's also something that I had one patient whom I allowed, he didn't want to give up his pump.
Yeah.
And I worked with him for about 2 years. He was doing great. We were having normal blood sugars, but he was on a low-carb diet, and he was using my methods for bolusing with the insulin pump. And remember, he was newly diagnosed.
Right.
So he was making a lot of insulin himself. But I warned him that eventually you're going to get scar tissue at the infusion site. And the insulin that the pump pumps in, including the boluses, are going to be unpredictable. And sure enough, after about 2 years, he ended up giving it up because it just couldn't work well anymore. So you can make it predictable for, and also, I don't know, I didn't check his C-peptide to see how much he was making, how much insulin he was making then versus at the beginning.
Yeah.
But as long as you're making a lot of your own insulin, almost any treatment works.
Yeah, that's true.
I have a number of type 2 diabetics who go on an approximate diet of mine where they don't weigh things, but they crudely estimate. And because we caught them early and they're still making a lot of insulin, they can get away with it.
Yeah. That's a different story. But once the beta cell starts deteriorating, it's a different story.
There's another point that doctors don't recognize. It's called glucose toxicity. And I don't know that glucose is necessarily toxic directly to beta cells. That concept has been challenged, and there's uncertain results there. But if you're pushing the beta cells to overwork, they do get burned out. That's why the sulfonylurea drugs, which push beta cells to work harder.
Yeah.
The doctors were warning people they're only good for 2 or 3 years. And the reason, they didn't give a reason. The reason is because they're pushing your beta cells to work so hard to make a lot of insulin.
Yeah.
That the beta cells are not going to last.
No, exactly. I think, one of the reasons I keep getting challenged on Facebook groups just generally a lot, because I just tend to say what you're saying, that the range, the whole concept of the range, safe range between 70 and 180 milligrams per deciliter is completely false, because it gives you the false hope of living your life with diabetes without complications, where we know exactly that that's not the case. It can't be the case with having such a wide range and fluctuations. Have you seen in your office lately the latest, I would say, relatively young person who sticked with this 70 to 180 dogma and got complications?
First of all, since COVID, I only do remote care. We use Skype. And I'm trying to think. I have one patient whose blood sugars are not in the realm that I like. He has a attention deficit disorder, and cannot really take care of himself. His parents have to really guide him, direct him continually, and the parents are divorced, and it's a dysfunctional situation.
Yeah.
And I think that he's beginning to get gastroparesis. But all my other young patients do very well. You know, parents are cooperative and understands. I have one kid whom I've been treating since he was 11 years old, when he was first diagnosed. The parents, somehow they managed to get to my book while he was still in the hospital, getting, I think, on a high carbohydrate diet, on the roller coaster blood sugars. And we started him then. He's now, I believe, 26, has his own business, making a lot of money. He's in another country, by the way, that he's not from the USA. So I've been treating him for 15 years. He's very diligent at taking care of himself. A1C 4.8 to 5.3.
Yeah. Yeah, that's something I wanted to ask you. After so many years in practice, do you see when patients, let's say, come through the door into your office and then spend some time with you, do you see a sort of some personality traits or character traits that are predictors of success in actually implementing your protocol? Because I speak to a lot of families, young families with young kids being diagnosed, and I get all sorts of excuses about, oh, my child is a fussy eater, oh, the kids in the school have bad influence on my kid, oh, I don't know, all sorts of excuses. Do you think it's down to like personal traits where some people are just diligent and parents are, I don't know, organized, or is it just what is it down to? Do you have any idea?
I think that a lot depends on the parents.
Mm.
And frequently, sometimes you run into situations where the parents are afraid of the children.
Mm-hmm.
And I do have one such parents situation, again, someone from another country, where the daughter really runs the household. I think I started with them when she was about 10, 8,
Mm-hmm.
and we never could get her under control.
Mm.
She would lie about what she ate. She would pretend to be taking insulin and not taking it. And so there have been non-successes, but they're usually situations where the situation at home
Yeah.
was always bad.
Yeah. Yeah, that's my impression as well. Okay. Moving on, I've got two more questions for you. One is about, I think I've heard it on one of your seminars that you've actually invited fellow doctors to actually come into your office to see how you treat diabetics, just to learn your method.
Yes, before COVID,
Mm-hmm.
when I had patients coming in, I would get permission from the patients to have an observer.
Mm-hmm.
And I actually, I still have in theory a course at the Albert Einstein College of Medicine where medical students, usually in the third year, where they have an elective, can spend 1 or 2 months observing, and they would talk to the patients, ask them questions, and observe what I was doing with them. I don't do that anymore because I don't have any patients in the office.
Right. Okay. But what sort of feedback did you get?
They would all say that it was their best rotation.
That's what I thought, because I remember you saying that you go through an 8-page long list of complications as part of your initial assessment. Is that still the case?
Oh, the physical exam.
Yeah.
Yeah, and the medical students, if they were lucky enough to get a brand new patient,
Mm-hmm.
we would do a physical exam, and it was 8 pages long.
Yeah,
And I would test things that doctors didn't even know about.
yeah, that was my impression as well.
And it was, and how did I know about these things? One was trial and error, and the other was because I read a lot and keep up with the journals.
Yeah, I think that's quite important, because
the most important thing that I was doing was the RR interval studies, which enable me to diagnose autonomic neuropathy, which correlates with gastroparesis. And I even learned what the RR study is really, the ratio of the heart rate on inhaling versus exhaling.
Yeah.
And normal is a ratio of something in a young person is something like 1.7, 1.8. And I discovered that the gastroparesis seems to occur when you get under 1.3.
All right, okay. And then
and it gets worse as you go under 1.2. It gets very bad when you get down to 1.15,
okay.
etc. And I even had published in the journal for a brief period of time. The editor of the journal Diabetes Care looked on me as an authority and thought that what I was doing was great. And he actually published my protocol for doing the RR interval studies. And rare people here and there are still looking at that old article and following my technique.
That's great. That's fantastic. I wanted to ask about the DCCT. Well, a question relating to DCCT, because I've read Gary Taub's latest book, where he basically gives a bit of a exoneration and vindication to, let's say, your part in making sure that people who are diabetics could essentially get normal blood sugars. But there's always a question from, let's say, the standard medical authorities about your methods not being trialed other than the DCCT, which only came halfway through, because obviously they haven't introduced the diet, they haven't introduced the exercise, they just insulined those people as much as they could. Now, do you think, because apart from the patients, is there anyone else who would let's say be interested in that kind of study? Because obviously the pharmaceutical industry wouldn't be necessarily interested in doing a trial of the diet itself, let's say, or diet and therapy, drug therapy, or insulin, metformin, or all sorts of other oral agents there are. Do you think that's ever going to happen?
What happens is trials of pieces of things. They'll compare one oral agent to another.
Yeah.
And some of these comparisons, and they're seeking what should I say, equivalence. And for example, there was one trial where a GLP-1 agonist was compared to a DPP-4 antagonist. Now, we've known for years that the DPP-4 antagonists were not very effective and also had a high incidence of adverse effects.
Yeah.
So here, a manufacturer is comparing his new product to junk, and it gets published.
Obviously, yeah, because that's the publicity he needs.
And so you have to be wary, even of clinical trials. You have to see who paid for it.
Yeah, true.
Etc. And you know in advance that if it's paid for by a certain manufacturer, it's going to be favorable.
Yeah,
and if it were unfavorable, it wouldn't get published.
Yeah, that's as simple as it gets, and
Yeah.
it's not going to get any better, I suppose, in the new feature. Okay.
So the patient, what it boils down to is ultimately the patient doesn't count.
Yeah, I think you even wrote it in your book that it's diabetes seems to be sort of like an orphan's disease where no one except for the patient actually cares really. That's what seems to be the case.
Yeah. And doctors are looking to their own protection.
Yeah, that's for sure.
To minimize their responsibility. So many of these doctors who supposedly specialize in diabetes have nurse educators or physician's assistants, I think, and they turn the patients over to the physician's assistant.
Wow. Okay. Interesting. That's probably what's going to happen in the UK because the NHS, so the body that is actually governing the medical services here in the UK, they are pushing for physicians associates. I think that's what they call them in here, to actually be the first line of, let's say, help or service in terms of medical profession. And these people usually only do get 2 years of some sort of medical course at the uni, and the rest is trained on the job. But I suppose that's not really very optimistic for the patient if they're being seen by a person who's only got 2 years at medical school.
Yeah.
Right.
So,
yeah.
I'd like to ask you a question. Are you married?
No, I'm not. No, I'm not.
How old are you?
I am 40 years old. I've just turned 40 in October.
Okay, so you look a lot younger.
I do, yes. Yes, I do. I get to hear that a lot, but yeah, I'm not, like I said, I'm not a spring chicken anymore.
Okay, well, it's good meeting you, Luke.
It was fantastic speaking to you,
thanks,
Bernstein.
thanks for translating into Polish. And I wish you a lot of luck. And if you need any advice career-wise, get in touch with me, okay?
Will do. Thank you very much again for your time.
Okay, good luck.
Take care.
Take
Bye
care.
now.